My name is Wes Turner, and I'll be presenting my poster of a case report on Achilles tendon rupture through an area of calcification. The Achilles tendon, despite its strength, is prone to injury due to two reasons. The first one being that it experiences exceptional forces and demands during activity. The second being that it has a watershed area about 6 centimeters proximal from its insertion on the calcaneus. There's been cases that have been reported in the literature of areas of ossification present in Achilles tendons, which has been thought to increase the risk of injuring, tearing, or fracturing through those ossified regions. This was first documented in 1932, and since then there's been 30 case reports and 4 case series in the literature. Our case that we present is a 68-year-old female with a history of a TIA who presents with left ankle pain and weakness after a fall downstairs 6 years prior to presentation. However, that was recently exacerbated 9 months prior to clinical presentation as she took a repeat fall downstairs. Her past medical history is significant for a TIA 2 years prior, as well as diabetes. She denies nicotine or tobacco product use. On physical exam, she has a rigid heel cord with a palpable defect 10 to 12 centimeters proximal from the insertion. She has a positive Mattel's test, and she has 4 to 5 plantar flexion. On initial radiographs seen in Figure 1, it demonstrates an extensive area of heterotopic ossification at the Achilles, measuring about 14 to 15 centimeters in length, with a 1 to 1.5 centimeter defect present. In Figure 2, there's an x-ray from a year prior that shows a large intact area of ossification that measures about 12 centimeters. CT with 3D recon is seen in Figure 3, which redemonstrates the aforementioned ossified tendon, as well as that area of separation. Our patient tried physical therapy as well as NSAIDs, was unsatisfied with the results, so opted to pursue surgical management. For operation, she underwent an excision of ruptured calcified Achilles tendon, FHL tendon transfer to calcaneus, Achilles tendon allograft reconstruction, as well as calcaneal bone resection. She was position prone and incision was done throughout the ossified region. It was dissected down and circumferentially prior to complete excision that can be seen in Figure 4. After that was done, the FHL was transected and tensioned through a drill hole into the superior portion of the calcaneus, aiming towards the plantar cortex. The FHL tendon was fixed in its transfer position with a tenodesis screw after it was appropriately tensioned, at which point an Achilles allograft was prepared in a V-shaped wedge fashion, and the proximal end of the tendon was interlocked to the allograft using fiber-wire sutures. Continued longitudinal traction was applied to create excursion, as well as to assess the appropriate tension between the remaining distal end of the native tendon, as well as the allograft. Once that was appropriately tensioned, fiber-wire suture was used in a locking fashion again and oversewn with monocryl. She was then placed in a short leg splint and plantar flexion and made non-weight bearing. The areas of calcification ossification were sent to pathology where it demonstrated benign bony growth, as well as fibrinous fibrotendinous tissues. Postoperatively, she had no complications. She was transitioned from a splint to a cast at 2 weeks. She remained non-weight bearing for 4 weeks. At that point, she was then transitioned to a cam boot with heel lifts on Achilles protocol. 10 months after surgery, she completed physical therapy, wears a cam boot intermittently for comfort. It says that her pain has decreased drastically, compared to pre-op. However, she still has some residual weakness and is unable to do a single leg heel raise. For the specifics of this phenomenon, it's very difficult to discern. It's theorized that patients with this pathology are often asymptomatic because they only have kind of vague symptoms of pain, swelling, reduced range of motion, and some weakness. But oftentimes it's not enough to warrant further evaluation by clinicians or for them to even present to a clinician. Risk factors are thought to be multifactorial, but some of the key ones are related to significant trauma, repeated microtrauma, previous Achilles or lower limb corrective surgeries done in pediatrics. On a biological level, hypotheses surrounding ossification include chronic tissue hypoxia that leads to an inflammatory cascade, which creates a shift in cell differentiation from collagen to bone. Various models of the cycles of injury and inflammation have been shown to influence molecular signaling pathways, such as BMP, TGF-beta, hedgehog, as well as Wnt signaling. In our case, it's impossible to say whether the area of ossification was present during her initial injury 6 years prior, or if she developed it as a result of that. She does deny any previous history of trauma or surgery to that lower limb. She's also a non-smoker. For other generalized tendon ossifications, there's been systemic inflammatory diseases which have been associated with it, such as DISH, Wilson's, Reiter syndrome, ankylosing spondylitis, and gout, none of which were present in our patient. When considering how to manage these, it's important to consider the extent of the ossification, where there's a presence of a rupture, the patient's symptoms, as well as their goals. Non-operative management should be considered when there is no fracture to the ossified region, if the patient still has preserved mobility, as well as the ability to bear weight. Also, if they have symptomatic improvement after a trial of physical therapy, non-steroidals, or topical adjuvants, as well as a trial of weight bearing and a cam boot to offload that area. If the results are unsatisfactory after that trial of non-op management, or if the patient has continued significant pain or limitations with weight bearing or range of motion, operative management should be considered. The goal should obviously be to restore the function tendon, continuity, and overall function. And this can be achieved through excision of the ossified region, and if there is a large enough defect, then bridging that gap with either an allograft or an autograft replacement. There's been various graft types that have been studied in the literature, such as Achilles allograft or autografts in the form of semitendinosus, gracilis, FHL, or fascial auto. There hasn't been any long-term studies showing outcomes or superiority, but there has been comments in the literature about surgeon preference, and that whatever the index surgeon is more comfortable and capable of doing will often have better surgical outcomes. In the conclusion for our case, the Achilles tendon ossification is a rare pathology with a complex and multifactorial etiology that continues to be poorly understood. Largest risk factors are history of previous injury or a history of surgery to that extremity. In the cases of significant ossification with a large residual defect or significant symptoms, surgical excision and FHL tendon transfer plus minus allograft or autograft may be a viable option for Achilles tendon reconstruction. However, our case is obviously limited as it is a single case study, and further research is warranted for specific treatment as well as specific causes for this pathology. Thank you for your time.